Hello and welcome to another series of MRCP by Dr. Raza. As we are already discussing hematology and oncology questions that are being commonly asked in the MRCP exam, whether it is part 1, part 2, or even PACES. So the common causes of eosinophilia that are being asked in the MRCP part 1 exam are asthma, allergic bronchopulmonary aspergillosis, Churg-Strauss syndrome, Loeffler syndrome, tropical pulmonary eosinophilia, eosinophilic pneumonia, and hypereosinophilic syndrome. So these are the common pulmonary causes. Allergic bronchopulmonary aspergillosis, or ABPA, is one of the commonly asked questions in the MRCP exam. The common infective causes are schistosomiasis, the infections caused by nematodes like Toxocara, Ascaris, Strongyloides, as well as caused by Echinococcus granulosus. Certain drugs like sulfasalazine and nitrofurantoin can also cause eosinophilia. Moreover, psoriasis, eczema, and eosinophilic leukemia, although very rare, but are the causes of eosinophilia. Eosinopenia, in other words, that is the decreased eosinophil count, is caused by Cushing syndrome and the use of steroids that lead to sequestration of eosinophils in lymph nodes. Hypereosinophilic syndrome is another commonly asked question in the exam, where the count of eosinophils is more than 1500 for more than 6 months, or more than 20% of the cell population in the bone marrow is comprised of eosinophils. So hypereosinophilia plus eosinophil-mediated organ damage is the cause of hypereosinophilic syndrome if other causes have been excluded already. The most common feature is the skin manifestation. It presents with pruritus, fatigue or myalgia, fever with night sweats, diarrhea, and the most common neurological manifestation is stroke. So if a young patient especially presents with stroke, so hypereosinophilia should be considered. Other symptoms depend on the organs that are involved. It can present as cardiac disease with chest pain and dyspnea, as well as with a respiratory disease, and the presentation can be dry cough. The first line treatment is the non-myeloid hypereosinophilic syndrome, and the treatment is glucocorticoids. FIP1 like 1 PDGFR alpha blockers in the form of imatinib are also being used for the management of hypereosinophilic syndrome.